Good morning, students. We will wait till everybody joins. I think we can start, right? Others, I don't know whether they are going to come or not. Okay. First of all, I'm very sorry that I uploaded all the slides and the videos, but uh, the slides and the videos in LMS, I don't have option for your batch. I had option only for R13. I didn't realize and I have uploaded everything. Yesterday when you sent message to Miss Vani only, I had a doubt and I rechecked, and all the slides are in R13. I have requested for access for your batch. Mostly I will be getting by today because yesterday was a holiday, so I couldn't get any access. So if I get today, then immediately I'll upload everything. Okay. Um, Otherwise, like I uploaded everything by Thursday itself. Then I didn't know, I didn't check properly that it is R13 or R12. Okay. So today, is there any doubt in shoulder joint? Okay. So if no, then we will go with elbow joint today. So elbow joint has three. One is humerus and the ulnar part, radius and the ulnar part. Then that is humerus will be directly joining with only ulnar. It will not have any much access to radius. Okay, so radius and ulnar will be having an articulating surface together. Then you will be having proximal, sorry, you will be having humerus and ulnar, humerus and radius. Then you will be having proximal radio ulnar articulation. So three articulation will be there in this elbow joint. As an elbow complex, there will be three articulating surfaces, three different set of articulating surfaces. Is that clear? So in that, this humerus and ulna will be having the major articulation. The other articulation will be very limited. Okay. So first is like humerus and the ulnar articulation. So here if you see the trochlea, that is trochlea will be convex in nature. Then the olecranon fossa will be concave in nature. Okay, so the trochlea will be convex in nature. The olecranon fossa will be concave in nature. So the resting position of this particular joint is elbow in 70-degree flexion and forearm in 10-degree supination. So when you keep the elbow 70-degree flexion and forearm in 10-degree supination, then the articulating surface will be loosely packed. So that is the resting position. So the treatment plane is on the olecranon fossa. So olecranon fossa is concave in nature and it is approximately 45 degree from the long axis of ulnar. So here the stabilization should be the proximal joint. So proximal joint is a shoulder joint. So you have to fix the shoulder joint or the humerus against the treatment table. So you can use a belt or an assistant to hold the humerus over the treatment table. So when you are keeping the belt or like when you are holding it, so you make sure that you fix the humerus with the other hand, or you fix the humerus with any like along with like how you will be stabilizing your uh, scapular joint. Same like that, you can stabilize your humerus also. So the indication is again whenever there is like if you want to increase the flexion or extension of the shoulder of the elbow joint, then you can use this humero-ulnar distraction and it is progression. So the position will be in supine lying with the elbow over the edge of the table or supported with padding just proximal to the olecranon process. So if you can see here, the humerus is stabilized with the belt along with the table. Okay, so the elbow will be in 70-degree flexion and the forearm is 10-degree supinated. So in this position, you have to fix the joint. This is the patient position. Supine lying with the hand in this particular position. So the therapist will be standing in box standing position near the treatment hand. then you have to hold the hand with both the both the hand like this. So the fingers will be overlapping each other, and it will be holding anteriorly. The thumb will be holding at the lateral aspect of the forearm. So in this position, you need to give a downward push. So when you give downward push, so that is your distraction of the humero-ulnar joint. Is that clear? So this like downward push. So in this push is your distraction. Okay. So in this distraction, slowly you can increase the angle. So from 70-degree, either you can go for reduce the flexion and go to 0, that is extension, or from 70-degree flexion you can increase the flexion and you can go to till 135 to 150-degree flexion. So that is your progression. So next is the distal glide. So distal glide will be in the same position, but you have to just give a scooping movement. Scooping movement means like how you scoop the ice cream. So that kind of scooping movement will be given. So if you see here, the rest everything is same. So along with the distraction, you just give a scooping movement. So instead of bringing down like this towards your body, you just give a scooping movement like this upward. Okay, so bring down, then upward, bring down, then upward. So this is called scooping movement. So this movement will give you the distal glide. This will help you to increase the flexion. So when you have restriction in flexion, if you want to increase the flexion, then you can go for this distal glide. Okay, is that clear? Next is humeral. So you want to see the video? So it's better if you see in between, right? One.
Go to about 7. He's got a goniometer. Who wants to challenge the professor? So this is about 90 degrees, is that not? Everybody sees that? So I want to go to about 7. He's got a goniometer. Who wants to challenge the professor? Oh, I win money on this one. All right, so it's about 70 degrees. This is neutral. Neutral position. I want her at what? About 10 degrees. About 10 degrees, that's all. Just a slight movement as far as the forearm's concerned. My hands are going to come into the ventral side, taking up the slack, and letting her wrist kind of come right across my shoulder. And I take up the slack, get my elbows together, and I'm kind of scooping. Okay? Not doing this. Can you see what I'm doing? Taking up the slack and scooping that elbow, the olecranon, away from the humerus. Rolling it out. Why is that? Because in this position, the olecranon is on a 45-degree angle. Okay? He's kind of like this. He's not straightening. Okay? So if I just do that, I'm not really getting him. So I let my shoulder kind of come in, and so her arm's resting onto my shoulder or onto my clavicle. So I got to get in there tight, don't I? And I get her in a position where it's comfortable for me. Reset. There's 90, about 70 degrees. There's neutral, about 10 degrees supination. My lateral, or I guess it would be the lateral side hand, grabs first. My other hand grabs over. In that position, get my elbows to my ribs. Don't want to be out here. Elbows to the ribs, because that's telling me the direction I'm going in. And I scoop and distract. Can you feel the distraction? Okay. It'd be ideal if I have a tech, and we can afford to have one, is to have them hold their shoulder down. Okay? So you don't always have that anymore. You don't have techs anymore.
I think I'm tempted to elevate.
Yeah, I tend to see that whole thing pull. So once again, I get in a position where I make sure that all this is not moving. So now's my starting point, isn't it? Do you see what I did with her shoulder? Now I'm just starting to do it. And there's my distraction. And even with that, look at how much her shoulder moves. But I can feel separation. She can feel it. And that feels good to
Okay, so the other video will be the long video. We will see it after completing this humeroradial and the proximal radioulnar joint. Okay, so next joint is humerus and the radius. So here, if you see, the capitulum will be a convex surface and the radial head will be a concave surface. So the articulation is between the convex capitulum and the concave radial head. So here the resting position is elbow end extended with forearm supinated at the end of the available range. That means elbow is completely extended and forearm is completely supinated. So that is the resting position. So the treatment plane again will be the concave surface, and the stabilization, you have to fix the humerus with one hand or with a belt or any other person. So here, if you see, this is the position of the person. So it will be fully extended along with the forearm is completely supinated. Okay. So this particular distraction is given to increase the humerus and the radial joint movement. So the patient, the therapist will be standing in between the patient and the patient's hand. So you need to keep the hand a little bit away from the patient's body, and the therapist will be standing in between the patient and the patient's body. Okay. Then you need to stabilize. Okay, stabilizing humerus can be with one hand or with other person's help. Then you will be giving the holding the, if you see here, one hand is stabilizing the humerus, end of the humerus, and another hand is just holding the radius. Okay, so another hand is holding the radius and giving the downward pull. This is your distraction. So it will be just coming down. So just hold the radius alone, not the whole complete forearm. If you see the picture clearly, you can make out here. So the hand is holding the radius alone, that is radial bone alone, and giving a downward pull. So this is your distraction of radius alone. Then next is like the glides between the humerus and the radius. So here you will be you can do the dorsal glide as well as the anterior glide. So the indication is dorsal glide will help you to increase the elbow extension. Volar glide will help you to increase the elbow flexion. So the patient position is supinated with elbow completely extended with forearm pronated, supinated. So the therapist will be standing in between the patient's body and the hand. Then you can stabilize the humerus with one hand. So if you see here, she is stabilizing the humerus, holding it down. Or you can, if you are not able to do, then you can ask any other person to support here, or you can wear a belt and support the humerus here. Then you will be holding the upper part or proximal part of the radius, then you will be moving it up and down. So when you move it up, it is volar glide. When you move it down, it is the dorsal glide. Okay, so you will not do up and down movement. You will be either doing upward movement or downward movement. So if you want to increase the flexion, you need to do upward movement alone. If you want to increase the extension, then downward movement alone. Okay, so you will be either completing one movement, then you will be going to the other movement. You cannot do both at the same time. Is that clear? So this is your humeroradial glides. Then next is, so you have a compression also in this particular joint, because if you see there is more chance of the radius coming out of the humerus. Okay, so here the radius sometimes will be just coming out of the annular band. So there is a ligament called annular ligament. So the radius will be inside that annular ligament. But sometimes, especially in the children, when you are pulling the hand alone, then there is more chance for the elbow to come out or sublux. So to reduce the subluxation, you can do this radial compression. So here what you can do is, so you have to stabilize the joint in 70-degree flexion, okay, and 10-degree supination. So that is the resting position. So you have to hold in that. Then you will be holding the humerus by holding the lower part. Okay, so you can stabilize the humerus with this hand. You can see here like a cupped hand. You have to stabilize the lower part of the humerus. Then hold the wrist like this, like a interlocking. So you have to keep your palm over the patient's palm in interlocking position. Interlocking position means like how you will be giving a shake hand. So interlocking position. So after holding the palm in interlocking position, you will be giving a downward pressure as well as you will be doing a reverse scooping movement. Okay, so you will be doing a downward pressure as well as you will be like a screwing movement you have to do. Okay, so you have to screw in such a way that the head is going inside the annular ligament. Is that clear? So this is to reduce the subluxation. This will help you to realign the joint inside the annular ligament. So next is proximal radio-ulnar joint. So proximal radio-ulnar joint is between the radius and the ulna. So the convex rim of the radial head will be articulating with concave radial notch of the ulna. So the resting position is 70-degree flexion with forearm supinated 35 degrees. The treatment plane is, again, it is a radial notch. It is a concave surface. Okay, so you need to stabilize the proximal ulnar here, because the movement should not happen at the elbow joint. It is just down the elbow joint. So you have to stabilize the proximal ulnar. Okay, so here you have again two glides. One is dorsal glide and the volar glide. You cannot give distraction, because if you give distraction, it will come out of the annular ligament. Okay, so you cannot give distraction here. So like the patient position is either in sitting or in supine lying position with the elbow in 70-degree flexion and 35-degree supination. So you can see here elbow is 70-degree flexion, then forearm is supinated 35 degree. So you can stabilize the hand. If you see, the down hand is stabilizing the humerus. So the with one hand you have to stabilize the humerus, then with the other hand you have to hold the radius, and you will be doing you will be either pushing forward or pulling backward. So pushing forward is your olar glide and pulling backward is your dorsal glide. Is that clear? So we will see the videos of it.
Is the humeroradial joint. For this mobilization, we're going to need a wedge to stabilize the humerus, and we're going to put the joint first in the resting position, have the patient put their elbow fully extended and their forearm fully supinated. This is the resting position of the humeroradial joint. So put the wedge underneath the humerus to stabilize the humerus. We're going to further stabilize the humerus with your hand, and then palpate the head of the radius where it articulates with the capitulum of the humerus. And first, I'm going to push the radius posteriorly, applying graded oscillations. This technique would help improve restricted extension because it is a concave radius on a convex capitulum. Then I can apply an anterior glide at the humeroradial joint, stabilizing the humerus in the same way and applying my graded oscillations. This anterior mobilization would help improve flexion at the humeroradial joint. This video describes how to mobilize the humeroradial joint. For this mobilization, we're going to need a wedge to stabilize the humerus, and we're going to put the joint first in the resting position, have the patient put their elbow fully extended and their forearm fully supinated. This is the resting position of the humeroradial joint. So put the wedge underneath the humerus to stabilize the humerus. We're going to further stabilize the humerus with your hand, and then palpate the head of the radius where it articulates with the capitulum of the humerus. And first, I'm going to push the radius posteriorly, applying graded oscillations. This technique would help improve restricted extension because it is a concave radius on a convex capitulum. Then I can apply an anterior glide at the humeroradial joint, stabilizing the humerus in the same way and applying my graded oscillations. This anterior mobilization would help improve
patient position. Is he in a good position?
Yes.
Okay. Is he comfortable? The long hand, which goes directly over that I do. As distal as I can on the limbing move without applying force there. It's a supporting. Works on the triceps, parallel to the ground. So we can do that by applying that. Now I'm a little more comfortable. You comfortable there? Put this arm where it's comfortable.
We have a convex
Proximal radial ulnar joint.
Very good. So with the proximal radial ulnar, the radius to the ulna, we have a convex outer ridge of the radial head that's going to be going and articulating with a concave ulna. So the convex concave rule comes into place. When the forearm goes into supination, we also have a ventral glide along with the rotation that takes place. So to enhance supination, I'm going to do a ventral glide of radius on ulna. And that takes place by getting the patient's humeral ulnar position at its open pack position of 70 degrees and the radial ulnar position in its open pack position of about 35 degrees of supination. I put my thumb onto the joint line. My cranial hand is on the joint line. My thumb is at the joint line, and I'm going to stabilize humerus. I'm going to come down with my other thumb into the caudal dimension, and I'm going to take the thumb onto the radius, and I'm going to push radius into this position. I'm also going to have my thumb come down from that position onto more of the ulna and radius so I can feel that movement. From that position, I'm going to go ahead and do a ventral distraction, ventral glide, I should say. Ventral glide. Going in this direction, it's going to enhance supination. Conversely, with pronation, the radius translates in a posterior direction along with rotation. So I'm going to be in the same position, take up the slack, and I'm going to pull him in a posterior direction. The radial head, taking up the slack, and pull in a posterior direction. Okay? Ventral, posterior glides of the radial ulnar joint.
Okay, so do you want to see it again or we will go to the next? Do you want to see it again or we'll go to the next?
Proximal radial ulnar joint.
Very good. So with the proximal radial ulna, the radius to the ulna, we have a convex outer ridge of the radial head that's going to be going and articulating with a concave ulna. So the convex concave rule comes into place. When the forearm goes into supination, we also have a ventral glide along with the rotation that takes place. So to enhance supination, I'm going to do a ventral glide of radius on ulna. And that takes place by getting the patient's humeral ulnar position at its open pack position of 70 degrees and the radial ulnar position in its open pack position of about 35 degrees of supination. I put my thumb onto the joint line. My cranial hand is on the joint line. My thumb is at the joint line, and I'm going to stabilize humerus. I'm going to come down with my other thumb into the caudal dimension, and I'm going to take the thumb onto the radius, and I'm going to push radius into this position. I'm also going to have my thumb come down from that position onto more of the ulna and radius so I can feel that movement. From that position, I'm going to go ahead and do a ventral distraction, ventral glide, I should say. Ventral glide. Going in this direction, it's going to enhance supination. Conversely, with pronation, the radius translates in a posterior direction along with rotation. So I'm going to be in the same position, take up the slack, and I'm going to pull him in a posterior direction. The radial head, taking up the slack, and pull in a posterior direction. Okay? ventral posterior glides of the radial ulnar joint.
Okay, so this is about the elbow joint. Now we will go to the next, that is distal radio-ulnar joint. So distal radio-ulnar joint is at the distal end of the radius and ulnar, there will be an articulating take place. So that is your distal radio-ulnar joint, and this articulation and the proximal radio-ulnar articulation will help you for supination and pronation. Okay, so in the distal part of radius and ulnar, the concave part of the ulnar notch of the radius will articulate with the convex head of the ulnar. So here again the treatment plane will be the radius articulating surface, because that is concave part. Then the resting position will be in forearm supinated 10 degrees. So forearm supinated 10 degrees is the resting position, and stabilization is like how you stabilize the distal humerus. Here you have to stabilize the distal ulnar, and you will be moving the radius. So the distal part of the ulnar is stabilized using one hand. So you can see here the distal part of the radius is the ulnar is stabilized using one hand, and the articulating surface of the radius is held by the other hand. Okay, so by holding here, the forearm is in 10 degrees supination. By holding here, you will be moving the joint, you will be moving the bone posteriorly, that is push the articulating surface. So that will be your dorsal glide, and whenever you pull your articulating surface, that will be your anterior glide. So pushing, so you have to do first either one side, either anterior or dorsal, then you go with the other one. So here the patient position can be in supination, in either in supine lying or in sitting position. So in sitting position, the forearm should be on the treatment table, and you will be doing from the resting position till the end of the available supination or pronation. That will be the progression. Okay, so this is the distal radio-ulnar joint glides. So next is radiocarpal joint. So radiocarpal joint is a radiocarpal joint. Here the radius will be articulating with the uh, proximal row of the carpals. So proximal row of the carpals will be found by three bones, that is scaphoid, lunate and triquetrum. So the concave part of the radius will be articulating with convex part of the distal row. Proximal row. So the proximal row is found by three bones, that is scaphoid, lunate and triquetrum. Okay, so the resting position will be in such a way that the radius should be in line with the third metacarpal. Okay, so the radius should be in line with the third metacarpal. So that is the resting position. So if you keep your hands little bit, you need to make the fingers little bit deviated, so that the third metacarpal will be in line with the radius of the radius bone. Okay, so that is the resting position. So here, as usual, the treatment plane will be the concave radius part and concave radius part. Okay, then you have to stabilize the distal radius and the ulnar together. So you need to stabilize the distal radius and the ulnar together. Okay. So this is the position. So you can either make the person to be in supine lying, or you can also make the person to be in sitting. So in sitting, you can keep the hand on the table, and you keep a towel under the wrist or forearm, because this is when you are doing a smaller joint, you may compress the body parts. So that's why you keep a towel so that you don't compress more. Okay, that is one thing. Then after keeping over the towel, you have to stabilize the distal humero-ulnar joint. Okay, so distal part you have to stabilize. You can hold at the distal carpal, or you can hold at the distal carpal bones. So you hold at the distal carpal bones and give a pull or distraction. So this is your distraction. So you hold the proximal articulating surface, then hold little down to the distal articulating surface and give a pull downwards. So that will be giving you distraction. So this movement can be done to initiate the treatment or to control the pain. So same position you can do for volar glide and the dorsal glide. So the dorsal glide will be uh, pushing downwards. So if you see here, this is the dorsal part. So when you are pushing upwards, then it will be giving you the dorsal glide. Is that clear? So this is the posterior part. So when you pull up, that is pushing upwards, then it will give you the dorsal glide. When you push downwards, that is towards the palm. So towards the palm, when you are giving the push, then it is the volar glide. So that is anteriorly. So volar glide will help you to increase the extension and dorsal glide will help you to increase the flexion. Okay. Then, so you have to keep the hand in neutral position. That is, in the initial, like you will be keeping in completely pronation. Then you have to keep the forearm in neutral position. So you keep the forearm in neutral position, stabilize the distal radio-ulnar joint, then hold the distal carpal bones with your other hand and give a push towards the radial side or push towards the ulnar side. Okay, so give a push towards this is your ulnar side. Give a push towards the ulnar side, that is called as ulnar glide. That will help you to increase the radial deviation. Then pull upwards towards the radial side. That is your thumb part is your radial side. Pull up towards the radial side. So that will give you the radial glide and that will help you to increase the ulnar deviation. Is that clear? So this is about the proximal radio-ulnar joint and the wrist joint. Okay. So we will see the videos.
Elbow slightly flexed. Okay, now we will be performing a joint mobilization on the distal radial ulnar joint. First thing, we're going to have the patient rest their arm on the plinth, elbow slightly flexed, and forearm supinated to 10 degrees. We supinate the forearm to 10 degrees because this is the resting position of the distal radial ulnar joint. You're going to stabilize the ulna with one hand, and you're going to mobilize with your other hand. Mobilize the radius with the other hand. So let's say the patient presents with restricted pronation or has generalized hypomobility. Pull the radius in an anterior direction to perform your graded oscillations while stabilizing the ulna. So if the patient presents with generalized hypomobility or has restricted supination, we can push the radius in a posterior direction. Perform your graded oscillations as necessary. We push in these specific directions due to the concave on convex rule at the distal radial ulnar joint. Okay, now we will be performing a joint mobilization on the distal radial ulnar joint. First thing, we're going to have the patient rest their arm on the plinth, elbow slightly flexed,
and forearm supinated to 10 degrees. We supinate the forearm to 10 degrees because this is the resting position of the distal radial ulnar joint. You're going to stabilize the ulna with one hand, and you're going to mobilize with your other hand. Mobilize the radius with the other hand. So let's say the patient presents with restricted pronation or has generalized hypomobility. Pull the radius in an anterior direction to perform your graded oscillations while stabilizing the ulna. So if the patient presents with generalized hypomobility or has restricted supination, we can push the radius in a posterior direction. Perform your graded oscillations as necessary. We push in these specific directions due to the concave on convex rule at the distal radial ulnar joint.
In our web space, the proximal row of I will now demonstrate a posterior to anterior and anterior to posterior mobilization at the radiocarpal joint. We'll start off by stabilizing the distal radius and applying in our web space the proximal row of carpals. As we stabilize the distal radius, we will apply a posterior to anterior force through the proximal row of carpals. This is a great technique to facilitate extension at the wrist. You can continue on by then stabilizing the proximal row of carpals and mobilizing the distal row of carpals. To do an anterior to posterior technique, we will ask the patient to supinate their arm. Again, we will stabilize the distal radius and apply in our web space the proximal row of carpals, and now we will go from an anterior to posterior mobilization. This will help to facilitate flexion at the wrist. Again, you can then stabilize the proximal row of carpals and mobilize the distal row of carpals. I will now demonstrate a posterior to anterior and anterior to posterior mobilization at the radiocarpal joint. We'll start off by stabilizing the distal radius and applying in our web space the proximal row of carpals. As we stabilize the distal radius, we will apply a posterior to anterior force through the proximal row of carpals. This is a great technique to facilitate extension at the wrist. You can continue on by then stabilizing the proximal row of carpals and mobilizing the distal row of carpals. To do an anterior to posterior technique, we will ask the patient to supinate their arm. Again, we will stabilize the distal radius and apply in our web space the proximal row of carpals, and now we will go from an anterior to posterior mobilization. This will help to facilitate flexion at the wrist. Again, you can then stabilize the proximal row of carpals and mobilize the distal row of carpals.
We're going to learn how to do arthrokinematic assessment and treatment for the ulnar capsule of the radiocarpal joint. Hi and welcome back to Physio Tutors. The aim of roll glide assessment is to gain information on reactivity of the joint and articular problems such as capsular limitations. For the push technique, have your patient in sitting position with the forearm in neutral position and supported on the bench. The patient's wrist is hanging freely. Then fixate the patient's forearm on the bench and grab the patient's proximal intercarpal row from radial. The intercarpals are the convex joint partner and the distal radial ulnar joint is the concave joint partner. So when moving with the convex joint partner, we will have to roll and glide into opposite directions. Now roll into radial and distal direction and at the same time perform the glide by pushing the proximal intercarpal row into ulnar and proximal direction. The proximal component is added as the distal radius reaches slightly more distal than the ulnar. An alternative is the pull technique. For this technique, the patient is either sitting or in supine position with the flexed elbow on the bench and the forearm in neutral position. The examiner is standing or sitting distal to the wrist to be assessed. Then fixate the patient's forearm with one hand and grab the patient's proximal intercarpal row from radially, like in an arm wrestling position. Now roll into radial and distal direction and at the same time perform the glide by pulling the proximal intercarpal row into ulnar and proximal direction. The proximal component is achieved by approximation. So you are pulling, but at the same time you are also pushing the intercarpals towards the radial ulnar joint. For all techniques, assess for movement quality during roll and glide, possible pain provocation, and end feel. For end feel assessment, roll and glide to end range, then assess if further gliding is possible or not. In a hypomobile joint, the glide is reduced relative to the roll component, so no further gliding is possible. If you feel that the end feel or movement quality is abnormal, you can directly move further from assessment to intervention as the techniques are identical. When used as an intervention, make use of the Maitland grades of mobilization to dose your techniques according to your goals. Check the video in the top right corner to learn more.
Okay, so this is the other one which will have the complete upper limb. Okay.
منطقة الفقر منطقة مشهورة جدا بنبقى محتاجين نعمل الموبيلايزيشن تكنيك عشان ايا كان مثلا واحد مثلا عمل كاست وعايز وبعد فتره معينه في ليميتيشن في الرينج اوف موشن او ايا كان، فبنحتاج ان احنا نعمل الموبيلايزيشن. عندنا الالبو جوينت تو جوينت، هيومرو النر وهيومرو راديال جوينت. كل واحد بيبقى ليه تكنيك معين. التكنيك بتاعت الهيومرو النر، كل الفكره في الهيومرو النر هنا تكنيك واحد بس. بنعمل ايه؟ سيباريشن للجوينت سيرفيس. تراكشن يعني سيباريشن. ببعد السيرفيس بتاعت الالنا عن الديستال اند بتاعت الهيومرس بنفس الشكل ده كده، ببعدهم عن بعض. الريستنج بوزيشن بتاعه 70 درجه فليكشن، 10 درجات سوبرفيجن، وباجي ايدي بتبقى بنفس الشكل ده كده عند البروكسيمال اند، وبس بركز اكتر ناحيه الايه؟ الالنا، وبعمل جوينت سيبريشن كده. ويفضل ان يبقى فيه ستراب يثبت الهيومرس. خلاص ده كده جوينت ايه؟ تراكشن. الريستنج بوزيشن بتاع الهيومرو النر جوينت 70 درجه فليكشن، 10 درجات سوباينيشن، وبريح الار عند الشولدر بتاعي. بحط ايدي هنا عند الالنا وبحرك الالنا ديستراكشن. السكوبينج تكنيك، بعمل ديستال جلايد للالنا عشان نحسن الرينج بتاع الفليكشن. من وضع الريستنج بوزيشن بعمل جريد 1 ديستراكشن وبشد الالنا في ديستال جلايد. الهيومرو راديال جوينت. الهيومرو راديال جوينت 3 تكنيكس بنستخدمهم فيها. التكنيك الاولاني عباره عن ايه؟ جوينت ديستراكشن. جوينت ديستراكشن ان انا بعمل سيبريشن للجوينت سيرفيس بنفس الشكل ده كده، ببعد السيرفيس عن الديستال اند بتاع الهيومرس. التكنيك الثاني عباره عن anterior glide وبوستيريور جلايد، anterior glide وبوستيريور جلايد. الانتيريور جلايد زي ما احنا شايفين الجوينت سيرفيس، البروكسيمال اند بتاعت الراديوس كونكيف والديستال اند بتاعت الهيومرس كونفكس. فانا لما اجي اعمل بوستيريور جلايد هيحسن الاكستنشن في السيم دايركشن، هعمل انتيريور جلايد هيحسن الفليكشن. الانتيريور جلايد بثبت البروكسيمال بارت اللي هي الديستال اند بتاعت الهيومرس. الريستنج بوزيشن الاول عباره عن ايه؟ البو اكستنشن وسوباينيشن، وايدي هنا عند البروكسيمال اند بتاعه الراديوس، وبحطها بنفس الشكل ده كده وبحرك في بوستيريور جلايد. من نفس الوضعيه اشد لفوق، يبقى ده كده انتيريور جلايد. الهيومرو راديال جوينت الريستنج بوزيشن بتاعه حوالي البو اكستنشن، 4 ار سوباينيشن، وباجي بثبت البروكسيمال بارت الهيومرس، وباجي هنا عند الراديوس وبحركها في بوستيريور جلايد. ممكن اسلوب تاني ان انا اشد الهيومرس لانتيريور جلايد لفوق. ديستراكشن تكنيك للهيومرو راديال جوينت، البيشنت بيبقى من الوضعيه حوالي سيمي فليكشن ومثبتين الهيومرس، وايدي هنا عند الديستال اند بتاعت الراديوس وبحرك في ديستراكشن. في تكنيك تاني بنستخدمه في الهيومرو راديال جوينت وهو الكومبريشن تكنيك. الكومبريشن تكنيك ده في حاله ايه؟ عندي انيولار ليجامنت وعندي الهيد بتاعت الريفلس. بعمل كومبريشن ده في حاله الديسلوكيشن، لما يحصل ديسلوكيشن للهيد بتاعت الراديوس بره الانيولار ليجامنت. بعمل ايه؟ بحاول اكمبريس الجوينت جوه الانيولار ليجامنت بنفس الشكل اللي هنعمله دلوقتي. بنيجي 90 درجة فليكشن، باجي أعمل كومبريشن. أولا أرجع تاني، الكومبريشن تكنيك بنحط إيدي هنا أجينست الهاند بتاعت المريض وبعمل كومبريشن ومعاه سوباينيشن بنفس الشكل ده كده عشان اروتيت الهيد بتاعت الراديوس جوه الانيولار ليجمنت واعمل ريدكشن للهيد جوه الانيولار ليجمنت. عندنا الحركه بتاعت البرونيشن والسوباينيشن بتحصل على تو جوينت، بروكسيمال راديو النر جوينت وديستال راديو النر جوينت. القاعده الثابته الديستال راديو النر جوينت الموفينج سيرفيس كونكيف على كونفكس، يبقى الجلايد في السيم دايركشن. لو انا عايز اعمل برونيشن يبقى بيحصل معاها انتيريور جلايد، سوباينيشن يبقى بوستيريور جلايد. الكلام ده فين؟ على مستوى الديستال راديو النر جوينت. البروكسيمال راديو النر جوينت العكس، الموفينج سيرفيس كونفكس على كونكيف، يبقى برونيشن معاه بوستيريور جلايد، السوباينيشن معاه انتيريور جلايد. الفور ارم الديستال راديو النر جوينت والبروكسيمال راديو النر جوينت. الديستال راديو النر جوينت بسيط، الريستنج بوزيشن بتاعه 10 درجات سوباينيشن من الميد بوزيشن، 10 درجات سوباينيشن من الميد بوزيشن، واحط ايدي عند الراديوس واثبت الالنا لان الراديوس اللي بتتحرك على الالنا، وبحركها في anterior جلايد posterior جلايد. نيجي على السيرفيس الجوينت البروكسيمال راديو النر جوينت. البروكسيمال راديو النر جوينت اهو السيرفيس اهو كونفكس واللي هنا كونكيف، فبالتالي الريستنج بوزيشن الاول بتاعه كام درجه؟ 70 درجه فليكشن و50 درجه سوباينيشن، وبحط ايدي هنا عند الراديوس وبحركها في anterior جلايد اللي بيحسن السوباينيشن، والبوستيريور جلايد بيحسن البرونيشن. الديستال راديو النر جوينت ليه اللوز باك بوزيشن بتاعه 10 درجات سوباينيشن من الميد بوزيشن، بنحط ايدينا بنثبت الالنا وايدي هنا عند مين؟ عند الراديوس وبحركها في anterior جلايد وبوستيريور جلايد. الفليكشن بتاع الراديو النر بروكسيمال راديو النر جوينت 70 درجه فليكشن و35 درجه سوباينيشن من الميد بوزيشن، وبنروح مريحين دراع المريض بنفس الشكل ده كده. بنثبت الراديوس من تحت والايد بتاعتي عند البروكسيمال راديو النر جوينت تحت الهيومرو راديال جوينت ب 2 ل 3 سم. بمسك الجوينت كده بحركها فيه anterior جلايد posterior جلايد. الريست جوينت عباره عن الكاربال بون والديستال اند بتاعت الايه؟ الراديوس والقطر. لما نيجي نعمل فليكشن الموفينج سيرفيس كونفكس على كونكيف، فبالتالي الانتيريور جلايد بيحسن الاكستنشن، والفليكشن بيبقى معاه بوستيريور جلايد. في وضع الريستنج بوزيشن كده بنثبت البروكسيمال بارت وبنيجي عند الكاربال بون ونحرك في بوستيريور جلايد. نقلب ونخلي العيان يعمل برونيشن، بنمسك الكاربال بون وبنثبت البروكسيمال بارت وبنحرك في anterior جلايد. بنثبت البروكسيمال بارت وبنمسك الكاربال بون، وطبعا بنبقى واضعين الجوينت في الريستنج بوزيشن سلايتلي فليكشن وسلايتلي النر ديفيشن، وبنمسك الكاربال بون وبنحركها في anterior glide. anterior glide. الانتيريور جلايد بيحسن الاكستنشن. نعكس. ايوه. بنثبت البروكسيمال بارت، نحط ايدي هنا عند الكاربال بون برضو، وبعمل بوستيريور جلايد. البوستيريور جلايد هيحسن الفليكشن. الفور ارم في الميد بوزيشن، وبنثبت البروكسيمال بارت عند الفور ارم، وايدي هنا بتمسك الكاربال بون. بعمل ulnar جلايد او ميديال جلايد. ulnar جلايد او ميديال جلايد هيحسن الراديال ديفيشن. عايز اعمل راديال جلايد عشان يحسن الالنر ديفيشن. بنيجي نثبت الديستال اسبكت بتاعت الفور ار، وايدي هنا عند الكاربال بون، وبعمل راديال جلايد. الميتاكاربوفالانجيال جوينت بنيجي من البوستيريور اسبكت بتاعت الكلام الاسكابولا حوالي كويس قوي. اول فيشن او سوبيريور جلايد. منطقه الفور ار منطقه مشهوره جدا، بنعمل الموبيلايزيشن تكنيك عشان ايا كان مثلا واحد مثلا عمل كاست وعايز وبعد فتره معينه في ليميتيشن في الرينج اوف موشن او ايا كان، فبنحتاج ان احنا نعمل الموبيلايزيشن. عندنا الالبو جوينت تو جوينت، هيومرو النر وهيومرو راديال جوينت. كل واحد بيبقى ليه تكنيك معين. التكنيك بتاعت الهيومرو النر، كل الفكره في الهيومرو النر هنا تكنيك واحد بس. بنعمل ايه؟ سيباريشن للجوينت سيرفيس. تراكشن يعني سيباريشن. ببعد السيرفيس بتاعت الالنا عن الديستال اند بتاعت الهيومرس بنفس الشكل ده كده، ببعدهم عن بعض. الريستنج بوزيشن بتاعه 70 درجه فليكشن، 10 درجات سوبرميشن، وباقي ايدي بتبقى بنفس الشكل ده كده عند البروكسيمال اند، وبس بركز اكتر ناحيه الايه؟ الالنا، وبعمل جوينت سيبريشن كده. ويفضل ان يبقى فيه ستراب يثبت الهيومرس. خلاص ده كده جوينت ايه؟ تراكشن. الريستنج بوزيشن بتاع الهيومرو النر جوينت 70 درجه فليكشن، 10 درجات سوباينيشن، وبريح الار عند الشولدر بتاعي. بحط ايدي هنا عند الالنا، وبحرك الالنا ديستراكشن. السكوبنج تكنيك، بعمل ديستال جلايد للالنا عشان نحسن الرينج بتاع الفليكشن. من وضع الريستنج بوزيشن بعمل جريد 1 ديستراكشن، وبشد الالنا في ديستال جلايد. الهيومرو راديال جوينت. الهيومرو راديال جوينت 3 تكنيكس بنستخدمهم فيها. التكنيك الاولاني عباره عن ايه؟ جوينت ديستراكشن. جوينت ديستراكشن ان انا بعمل سيبريشن للجوينت سيرفيس بنفس الشكل ده كده، ببعد السيرفيس عن الديستال اند بتاع الهيومرس. التكنيك الثاني عباره عن anterior glide وبوستيريور جلايد، anterior glide وبوستيريور جلايد. الانتيريور جلايد زي ما احنا شايفين الجوينت سيرفيس، البروكسيمال اند بتاعت الراديوس كونكيف، والديستال اند بتاعت الهيومرس كونفكس. فانا لما اجي اعمل بوستيريور جلايد هيحسن الاكستنشن في السيم دايركشن هعمل انتيريور جلايد هيحسن الفليكشن. الانتيريور جلايد بثبت البروكسيمال بارت اللي هي الديستال اند بتاعت الهيومرس. الريستنج بوزيشن الاول عباره عن ايه؟ البو اكستنشن وسوباينيشن، وايدي هنا عند البروكسيمال اند بتاعه الراديوس وبحطها بنفس الشكل ده كده وبحرك في بوستيريور جلايد. من نفس الوضعيه اشد لفوق يبقى ده كده انتيريور جلايد. الهيومرو راديال جوينت الريستنج بوزيشن بتاعه حوالي البو اكستنشن 4R سوباينيشن، وباجي بثبت البروكسيمال بارت الهيومرس وباجي هنا عند الراديوس وبحركها في بوستيريور جلايد. ممكن اسلوب تاني ان انا اشد الهيومرس لانتيريور جلايد لفوق. ديستراكشن تكنيك للهيومرو راديال جوينت، البيشنت بيبقى من الوضعيه حوالي سيمي فليكشن ومثبتين الهيومرس وايدي هنا عند الديستال اند بتاعت الراديوس وبحرك في ديستراكشن. في تكنيك تاني بنستخدمه في الهيومرو راديال جوينت وهو الكومبريشن تكنيك. الكومبريشن تكنيك ده في حاله ايه؟ عندي انيولار ليجامنت وعندي الهيد بتاعت الراديوس. بعمل كومبريشن ده في حاله الديسلوكيشن، لما يحصل ديسلوكيشن للهيد بتاعت الراديوس بره الانيولار ليجامنت بعمل ايه؟ بحاول اكمبريس الجوينت جوه الانيولار ليجامنت بنفس الشكل اللي هنعمله دلوقتي. بنيجي 90 درجه فليكشن، باجي اعمل كومبريشن. اولا ارجع تاني، الكومبريشن تكنيك بنحط ايدي هنا اجينست الهاند بتاعت المريض وبعمل كومبريشن ومعاه سوباينيشن بنفس الشكل ده كده عشان اروتيت الهيد بتاعت الراديوس جوه الانيولار ليجامنت واعمل ريدكشن للهيد جوه الانيولار ليجامنت. عندنا الحركه بتاعت البرونيشن والسوباينيشن بتحصل على تو جوينت، بروكسيمال راديو النر جوينت وديستال راديو النر جوينت. القاعده الثابته الديستال راديو النر جوينت الموفنج سيرفيس كونكيف على كونفكس، يبقى الجلايد في السيم دايركشن. لو انا عايز اعمل برونيشن يبقى بيحصل معاها انتيريور جلايد، سوباينيشن يبقى بوستيريور جلايد. الكلام ده فين؟ على مستوى الديستال راديو النر جوينت. البروكسيمال راديو النر جوينت العكس، الموفنج سيرفيس كونفكس على كونكيف، يبقى برونيشن معاه بوستيريور جلايد، السوباينيشن معاه انتيريور جلايد. الفور ارم الديستال راديو النر جوينت والبروكسيمال راديو النر جوينت. الديستال راديو النر جوينت بسيط، الريستنج بوزيشن بتاعه 10 درجات سوباينيشن من الميد بوزيشن، 10 درجات سوباينيشن من الميد بوزيشن، واحط ايدي عند الراديوس واثبت الالنا لان الراديوس اللي بتتحرك على الالنا وبحركها في انتيريور جلايد بوستيريور جلايد. نيجي على السيرفيس الجوينت البروكسيمال راديو النر جوينت. البروكسيمال راديو النر جوينت اهو السيرفيس اهو كونفكس واللي هنا كونكيف، فبالتالي الريستنج بوزيشن الاول بتاعه كام درجه؟ 70 درجه فليكشن و50 درجه سوباينيشن، وبحط ايدي هنا عند الراديوس وبحركها في anterior glide اللي بيحسن السوباينيشن، والبوستيريور جلايد بيحسن البرونيشن. الديستال راديو النر جوينت لللوز باك بوزيشن بتاعه 10 درجات سوباينيشن من الميد بوزيشن، بنحط ايدينا بنثبت الالنا وايدي هنا عند مين؟ عند الراديوس وبحركها في anterior glide و posterior glide. الفليكشن بتاع الراديو بروكسيمال راديو انر جوينت 70 درجه فليكشن و35 درجه سوباينيشن من الميد بوزيشن، وبنروح مريحين دراع المريض بنفس الشكل ده كده. بنثبت الراديوس من تحت والايد بتاعتي عند البروكسيمال راديو انر جوينت تحت الهيومرو راديال جوينت ب 2 ل 3 سم. بمسك الجوينت كده بحركها فيه anterior glide posterior glide. الريست جوينت عباره عن الكاربال بون والديستال اند بتاعت الايه الراديوس والقطر. لما نيجي نعمل فليكشن الموفينج سيرفيس كونفكس على كونكيف، فبالتالي الانتيريور جلايد بيحسن الاكستنشن، والفليكشن بيبقى معاه بوستيريور جلايد. في وضع الريستنج بوزيشن كده بنثبت البروكسيمال بارت وبنيجي عند الكاربال بون ونحرك في بوستيريور جلايد. نقلب ونخلي العيان يعمل برونيشن، بنمسك الكاربال بون وبنثبت البروكسيمال بارت وبنحرك فيه anterior جلايد. بنثبت البروكسيمال بارت وبنمسك الكاربال بون، وطبعا بنبقى واضعين الجوينت في الريستنج بوزيشن سلايتلي فليكشن وسلايتلي النر ديفيشن، وبنمسك الكاربال بون وبنحركها في anterior glide anterior glide. الانتيريور جلايد بيحسن الاكستنشن. نعكس، ايوه، بنثبت البروكسيمال بارت، نحط ايدي هنا عند الكاربال بون برضو وبعمل بوستيريور جلايد. البوستيريور جلايد هيحسن الفليكشن. الفور ارم في الميد بوزيشن وبنثبت البروكسيمال بارت عند الفور ارم، وايدي هنا بتمسك الكاربال بون. بعمل ulnar جلايد او ميديال جلايد. ulnar جلايد او ميديال جلايد هيحسن الراديال ديفيشن. عايز اعمل راديال جلايد عشان يحسن الالنر ديفيشن. بنيجي نثبت الديستال اسبكت بتاعت الفور ار وايدي هنا عند الكاربال بون وبعمل راديال جلايد. الميتاكاربو فالانجيال جوينت ما بين البروكسيمال فالنكس
Okay, so before going into the next couple of phalangeal joint, so do you want a break? So time is 9:25. We will meet back by 9:35. Have you all had your breakfast? If you want to have your breakfast, then I'll give you 15 minutes time. So we will meet by 9:40. Okay. Hello. Can we start? Okay. So next is carpal bones. Then we have like that is like we have a joint in between the carpal bones. Then we have carpals and the metacarpals, then the metacarpal and the phalanges. Okay, so all this are the remaining joints. So we have seen till the wrist joint, that is the distal radioulnar joint and distal radioulnar and the proximal row of carpals will be joining together to form the wrist joint. Then after that, if you see, there is proximal and the distal carpal bones will be joining. Then all the carpals will be joining together in between. Is that clear? So we will see that. So here if you see the carpal bones means like there are 8 carpal bones, and each carpal bones have to have carpal bones have to uh, will be giving or will be supporting for the complete range of motion of the wrist or also the fingers. Is that clear? So especially to the wrist. So here if you see, make the person to be sitting in a sitting position, and the therapist will be holding the patient's hand. So the elbow will be hanging unsupported. So that means you will be just holding the hand of the patient where the elbow will be unsupported and it will be hanging. So when the elbow is hanging, because of the gravity, it will be giving you a pull at the elbow. So this pull at the elbow will give a slight distraction to the distal radioulnar joint and the carpals. That means the gravity will be giving a pulling effect, and this pulling effect will be giving a distraction in between the carpal bones. Is that clear? So we don't need to give an additional distraction. So completely the position itself will give a slight distraction in between the joints. Okay, so you need to we need to hold at the carpals. So here, since it is since there are like 4 bones will be in the proximal row and remaining 4 bones will be in the distal row. So what you have to do was you have to hold in such a way that the bone which you are going to stabilize should be stabilized in the palmar aspect through with your index finger. Okay, so the bone which you are going to stabilize will be stabilized with your palmar in the palmar aspect with your index finger. So you can just see here. So this area, so that means like the proximally, if you want to stabilize, you have to stabilize using the volar surface. Like you need to stabilize at the volar surface using your index finger. Okay, so this is the stabilizing unit area. Then using the thumb, you need to do the movement for the particular carpals. So you have to place the index finger over the carpal which you need to stabilize, and the nearby or the distal row which you need to give the glide should be hold at the by the thumb, and you need to give the gliding. So you can see here. So if you want to increase the extension, you need to stabilize the bones, like stabilize the bone which is having the concave part. So that is the proximal carpal bones will be in a concave part. So that part you need to stabilize, and that part is stabilized using the middle finger at the volar aspect, and the distal will be mobilized by the thumb. So you have 3. So you can just see, like you position the dorsum of the thumb over the convex scaphoid, and you need to give the movement. At that time, the stabilization is at the distal radius. Is it clear? So you will be stabilizing the distal radius with the index finger, and you will be moving the carpal bones. So first you can move scaphoid, then lunate, then the trapezium and the trapezoid unit together. Is that clear? So together also you will be able to stabilize, move the part. Then thumb will be placed on the convex capitate. That is like you need to move the capitate, and the index will be stabilizing the lunate. So Each bone separately you need to see whichever bone you want to move have to be placed whichever bone you want to give the glide, you have to use the thumb finger. Whichever bone you want to stabilize should be stabilized using the middle finger. So that is on the volar side, and the distal side you need to do the movement. Is that clear? So you have 8 bones, so all 8 bones can be mobilized separately. Only one thing is, whichever bone you want to stabilize must be using the index finger. Whichever bone you want to move should be using the thumb finger. So you will be giving the push down. That means it is a volar glide. You will be giving a volar glide. Is that clear? So this will help you to increase the extension. Then to increase the flexion, you need to stabilize using that is, it is just opposite. You need to stabilize using the index finger under that particular bone, and you have to move the thumb. So you can just see. So here you are going to stabilize the distal rows of the carpal, and you are going to move the proximal. Okay, so the stabilization is given using the middle finger in the distal row, and the proximal rows will be moving. Okay, in the extension, like whenever you are doing the for extension, you will be stabilizing the proximal and you will be moving the distal bones. Here you will be stabilizing the proximal bone and you will be moving the distal bone. Okay, so for example, for the proximal row, if you want to do the movement, then you need to stabilize the scaphoid and you will be moving the distal radioulnar. So like that, scaphoid, triquetrum and the trapezoid, all you will be stabilizing the proximal and you will be moving the distal radioulnar. Then below that, the proximal, when you want to move the proximal carpal bones, you need to stabilize the distal carpal bones using the middle finger. Then you will be moving the proximal row of the carpal bones. Is that clear? So next is carpals and the metacarpal carpal joint. So all the carpals will be having a, that is like, it will be having a metacarpal joint. So we will be having 5 metacarpal carpometacarpal joint. So you need to stabilize the the hand, that is the carpal bones have to be stabilized, and the movement will be given at the metacarpal bones. Is that clear? So you need to stabilize the carpal bones and the movement will be given at the metacarpal joints. So first is distraction. Using one hand you have to stabilize both the proximal and the distal carpal bones. So using this hand you can stabilize both the carpal proximal and the distal carpal bones have to be stabilized using this hand. Then especially that particular carpal you can stabilize using the thumb. Then using the other hand thumb you will be giving the distraction movement. Is that clear? So using the other hand thumb you will be giving the distraction movement. So this is distraction. Then next is your glide. So for that, the resting position is midway between flexion and extension, or midway between, that is the hand should be placed in such a way that it is in the neutral position, midway between the flexion, extension, abduction and adduction. So in that case, if you see, the thumb will be in a neutral position, in a position that in such a way that it is trying to hold the cup. Okay, so it is midway means like it will be in such a way that it is holding a cup. So that is the resting position for the carpometacarpal joint of the thumb. Then you need to fix the triquetrum with the hand that is closer to the patient. Then you have to the trapezium is the concave part which will be the treatment plane. Then so in that position, so this is the position that is in such a way that it is holding a cup. So the thumb is in between the flexion, adduction, abduction, adduction movement. So with this hand you have stabilized the trapezium, and with the other hand you are holding the carpometacarpal joint of the thumb. Then with that you have to You can apply a longitudinal traction to give distraction. Then you can do the glide, that is you can push towards the little finger, that is your ulnar glide. You can pull away from the little finger, then that is your radial glide. Is that clear? So this is your ulnar glide. So in this position, you will be, it will be easy for you to give the ulnar glide, that is you have to push the carpo-metacarpal joint of the thumb towards the index finger. So this is your ulnar glide. Then this is your dorsal glide. So you can keep the hand in supination, hold the thumb in the same position, that is in between your finger, in between the abduction, adduction, flexion, extension of the thumb. You have to hold it in a neutral position. Then you give a push downwards. So that is your dorsal. Downwards means towards the posterior aspect of the hand. Then in the same position you can hold and you can give towards the radial side. So this is your radial glide. Then with the same position you will be able to hold and pull up, that is towards the palm. So that is your polar glide. So this is for your thumb carpo-metacarpal joints. So the remaining will be same for the remaining fingers. You will be giving the same distraction. Each finger you will be giving the same distraction. So next is like metacarpal phalangeal joint and the interphalangeal joint. So the resting position will be in slight flexion of the resting position is in slight flexion of all the joints, and the treatment plane is the distal part, and the stabilizing part will be also the proximal joint. Okay, so you will be stabilizing the carpometacarpal joint and you will be giving a pull at the interphalangeal joint. So that is your longitudinal distraction. So the gliding will be like you will be either giving in the olar side or dorsal slide. So you have to keep the hand in the resting position, then stabilize the metacarpal joint and move the interphalangeal joint. So if you move towards the anterior side or towards the palmar side, it is volar glide. Towards the dorsal posterior side, then it is the dorsal glide. Towards the thumb will be radial glide, and towards the ulnar will be the uh, ulnar glide. Okay, so this is about the interphalangeal joint. So you are having another class, right, by 10 o'clock. So I stop here. So we will see the video of this joints in the next class. Hopefully I will be getting the access by today. So most probably in the morning itself I will upload all the slides. You just go through before the next class. Is that okay? Okay, thank you.